in 30 minutes is to discuss about carbapenems. And this is an issue which is quite important. And, you know, you cannot discuss this in 30 minutes because this is something like equivalent to the world climate crisis. And the learning objectives are, I'm going to address the problem of Carbapenem-Resistant Enterobacteriaceae. Nowadays it's changed to Enterobacteriaceae, both globally and nationally, and the mechanisms, how the bacteria, the Enterobacteriaceae develop resistance, and our local experience here in Tukurambesa, and what possible options do we have to spare carbapenems, because these are our last tools or armamentarium in the fight against gram-negative infections. So some 46 years back, the United States Surgeon General said the war against infectious disease has been won. So the focus should be to non-infectious diseases. This was 46 years back. And you know, you could see in 2013, the chief medical officer in the United Kingdom said, the apocalyptic scenario is that when I need a new hip in 20 years' time, I will die from a routine infection because we have run out of antibiotics. So you could see how grave the condition is. You know, some 46 years back, we thought we defeated the bacteria. And in fact, you know, that was a downturn in the process of developing new antimicrobial agents. And, you know, that field is almost dry. And now we are on the verge of collapsing, because this is taken now by the United Nations as equivalent to a nuclear disaster to the world, or world climate change, what would that cause to the world. So the problem with CRE in general is, you know, in the 1960s, after the development of ampicillin, this is a semi-synthetic antibiotics. And the very interesting thing about antimicrobial resistance is it just follows the development of a new antimicrobial agent. So now what we say is, for all antimicrobial agents, there are possible resistant bacteria by one or different mechanisms. So the carbapenems were developed in the early 2000s, and as you could see, lots of bacteria have emerged with resistance, and it has spread all over the world. So this is really a serious issue. Because at one point in time, we're striving for having carbapenems, and we thought if we have carbapenems, then we are going to solve our problems with you know, particularly with extended spectrum beta-lactamase. In gram-negative, mortality would improve. It's like, you know, if you have a hammer, whatever you see tends to look like a nail. So antibiotics by themselves are not really a solution. Even if now we have a new generation or a new antimicrobial agents on board, I don't think, unless we change our practice and unless we have to use them pragmatically, it's very difficult to avoid resistance. Same kind of apocalyptic scenario would develop. So this is what the CDC labels are the superbug. Okay, the Carbapenem-Resistant Enterobacteriaceae. Enterobacteriaceae are the gram-negative organisms. These are primarily responsible for sepsis in hospital care situations, in hospitalized patients, as well as in the community settings. So by definition, this is resistance to imipenem, either one of these four, imipenem, meropenem, doripenem, or ertapenem. So these are spread by person-to-person contact in the hospital, particularly with poor hand hygiene. So hospital staff serve as vector, and also the surroundings could be fomites as well, could be contaminated. Like, you know, in Tukurambasa, we have shown that all the floors, all the surfaces are really soiled with Acinetobacter baumannii. And these are everywhere. Pseudomonas you find it around the top, wherever there are wet surfaces. So this primarily, the spread is by person-to-person contact and from the environment, but not by coughing or sneezing. WHO has listed, you know, these Enterobacteriaceae, Pseudomonas aeruginosa, Acinetobacter, resistant to carbapenems as a top priority, and to which, you know, the CDC does agree, and we need a new agent on board. And actually, in our setting, we don't have one yet. So the CREs, now I'm going to refer to CRE. I will say CRE when I'm going to refer to Carbapenem-Resistant Enterobacteriaceae. And these are everywhere. And this is just to show you the endemic areas. Africa, as you know, always evidences are neither not generated nor are delayed. So the fact that you don't see, you know, pointed in the sub-Saharan Africa, it does not mean that. I know that it is an issue in Kenya and a serious issue in South Africa because they are looking for it. Unless we go for it, we are not going to find it. But it is everywhere. Particularly in Tukuramvasa, I believe we are in a dire condition. We are really in a serious condition. So the most common CREs are KPC, NDM. I'm going to refer to this, but making aware that most of my audience are not infectious disease specialists. So we did this study for more than 3 years into Kurambasa Hospital. What we have come across is Enterobacteriaceae are the commonest cause of bloodstream infection in our setting in Kurambasa, and it used to be before 2015, it was E. coli, but now it is Klebsiella pneumoniae. And we think the KPC, Carbapenemase-resistant Klebsiella pneumoniae, has spread, and it has become the dominant species to cause bloodstream infection in Kurambasa Hospital. And what we have come across again from our study is the longer the duration of patients are put on broad spectrum agent. These are the risk factors, and also prior exposure to ceftriaxone. And these are identified risk factors. So from our study, as you could see here, is a very important slide. You see the two most important bacteria are E. coli and Klebsiella among Enterobacteriaceae. And here you will see that now Klebsiella is dominating. It used to be in the neonatal ward, but now in general, in the adult ward, including the surgical wards, it is Klebsiella pneumoniae. And as you could see, nearly 20% of the strains are resistant to meropenem. So this is a phenotypic test. Okay, so there are a number of caveats in relation to phenotypic test, but you could easily understand that 20% of the gram-negative strains, Klebsiella pneumoniae, have already started producing, have already become CRE. And as you could see here, a very good alternative drug for us to be able to use in order to spare carbapenems, ideally, as you could see here, is amikacin. We have repeatedly shown that this. You could see how resistance to ceftriaxone has it's overwhelming. 80% of the gram-negative bacteria are ESBL. resistant to third generation cephalosporins. So why CREs are really a concern? If a bacteria, a gram-negative bacteria, which are the common cause of bloodstream infection in hospitalized patients, particularly, including ours, like in our heme oncology patients, in patients whom we are treating in the critical care wards. These are, if we diagnose CREs, it is difficult to treat. And even in the best care, mortality could go up to 50%. And this study compared 14-day mortality in patients with who had developed Carbapenemase producing Carbapenem-Resistant Enterobacteriaceae. So I'm going to classify them as Carbapenemase producers and non-Carbapenemase. This is the enzyme that hydrolyzes the beta-lactam ring of carbapenems in general. So it is a mortality rate is higher with CP carbapenemase producing CREs compared to non-carbapenemase producing CREs. So it's really very, very little. And as you could see, the MIC got very, very high when CPCRE develops, meaning the least dose that you require to inhibit, the minimum dose, increases by far. Can you hear me? Eddie? Hello?
Yes, doctor, yes.
Okay, so what are the mechanisms of resistance? I try to be very relevant. So there are 4 possible, resistance is defined, this is a standard definition. So when we say MDR, the bug is resistant to at least one agent in 3 different classes. XDR, you have 2 possible options from 2 different categories. Pan-drug resistant, so you have no options. So we have all these bacteria into Curambessa. I'm just discussing the gram-negatives, Enterobacteriaceae. Okay, so most of them are MDR. So the beta-lactams are the most important tools that we have in the fight against bacterial infection. They inhibit cell wall synthesis. So what you have to understand is those bacteria which do not have cell wall, like Mycoplasma, Chlamydia, Legionella, and so on, are resistant to beta-lactams, including carbapenems. So carbapenems do not work against bacteria which do not have cell wall synthesis. So these are and their spectrum of action is wide. It includes gram-positives, gram-negatives, and anaerobes. There is no agent with such broad spectrum activity. That's why we say the carbapenems are the most important class and our last resort in our fight against serious infections. So here you will see this is a beta-lactam ring and an adjacent 5-carbon ring. And this is shared by all carbapenems, and the R1, there are 2 attachments. The R1 defines the PK property, and the R2 defines the spectrum of action of each carbapenem agent. So these are the agents. So as you could see, we have all are parenteral. So except doripenem, we have all the other carbapenems. We have imipenem, celastatin, we have meropenem, and we have ertapenem. We don't have doripenem yet. So the resistant mechanism can be classified as, in 2 broad categories. One is mediated by an enzyme, carbapenemase, which is a hydrolytic enzyme, which hydrolyzes, using a metal like either serine or zinc in order to facilitate the hydrolysis process. So we call these carbapenemase producing CREs. These are the most important because this is acquired through plasmid, and bacteria here share plasmids. So what we think into Curambessa is it is Acinetobacter which is training our rather gram-negative organisms. I'm referring to Klebsiella, E. coli, Proteus, and so on. The bar trick to overcome antibiotics. So the other mechanisms which I'm going to refer as non-carbapenemase producing, that explain the resistance again, that explains the mechanism in non-carbapenemase producing CRAs is alteration in the binding targets, which is a PBP, the penicillin binding protein, and an increase in the expression of efflux pump, and also down regulation or less production of porins. But the most important is mechanism is CPCRA, carbapenemase production. This is another view. So you could see here, it could be due to carbapenemase. So the most important carbapenemase are KPC, carbapenemase producing Klebsiella pneumoniae. This is becoming the dominant species in Corymbus. And you cannot treat this bacteria with the drugs that we do have here. So we need colistin, other agent, tigacycline, and so on. Part of the reason why we have high mortality among our hem-oncology patients, our patients in the critical care service, is because of the spreading KPC. The other ones are the metallo-beta-lactamase, NDM, VIM, and also you have the class D. This is according to Amber classification based on the amino acid sequences. So these explain the non-carbapenemase. So this is shared, transmitted by plasmids. This could be due to by mutation or chromosomal change. Okay, but this is a more serious one, and this is which is spreading fast in our setting. So these are, I have already mentioned this. So the gravity of the problem, why we are concerned, is if we fail with these agents, carbapenems, then, if the problem the patient does have is related to gram-negative bacteria, bloodstream infection or sepsis, the patient is very likely to die. Okay, so now the study in South Africa showed that they are doing molecular and genetic studies. KPC and OXA48 dominate in South Africa. We don't know which. We are just we have presumptive. We are just hypothesizing that because we are using carbapenems, we have Klebsiella pneumoniae dominating, so we think the strains are KPC, but we haven't yet done molecular and genetic tests, which we actually have to do. So what that means is if the bug is resistant to carbapenems, you have very little option to treat with, very, very little. The agents that we are going to use are highly toxic, like colistins and tigacycline, and also a number of other new agents that a combination of beta-lactam with beta-lactamase inhibitors, which we do not have. So this is a serious condition. So what are the kind of patients who are most at risk? The kind of patients who are most at risk are those patients who are hospitalized, those patients who have indwelling in medical devices or catheters, or on mechanical ventilators, or patients who have been given broad spectrum like third-generation cephalosporins, or have been exposed to carbapenems before. And these, particularly the hem-oncology patients, these are the ones who are at highest risk of CREs. So the bugs that are of serious concern for us are the Enterobacteriaceae, Pseudomonas, Acinetobacter. But one thing is, very interesting. One bacteria can have different mechanisms. So in addition to having the enzyme beta-lactamase, this is a beta-lactamase, they can also have other mechanisms. So bacteria develop different mechanisms to overcome antimicrobial agents. So what is the driving force for increased resistance increased use. Nowadays, we are using antimicrobials, and I would say that now if you go to any one of the wards in the Kurambesa, the medical wards I am referring to, almost I would say 95% of our patients are already receiving beta-lactam group of antibiotics, ceftriaxone in particular, ceftazidime, cefepime. These are the driving force, okay? So the end result is increased resistance, particularly to carbapenems, our last resort in our fight against gram-negative bacteria, which are the commonest cause of bloodstream infection in hospitalized patients all over the world, including ours. In which case we have to use, if we have to treat, now I think it's high time that we need to have polymyxins. We need to have polymyxins and other novel agents, which we do not have. Actually, I have an experience of treating 2 patients in our ICU, and they survived. Both patients survived. So we were able to import polymyxins, colistin from abroad, and they survived. So it's high time that we need now in our country polymyxins. So in order to share with you our local experience here, kind of patients, who are given carbapenems are most of the patients actually do not need. Particularly, it's commonly, it is a drug that is misused or inappropriately used. Like for instance, in a case here, she's a medical student with type 1 diabetes taking insulin. She had asymptomatic bacteriuria due to E. coli, and she was given a number of antibiotics. And last, the doctor decided doing a culture, and the culture showed only sensitive to meropenem. But this is a patient who doesn't need treatment because she has asymptomatic bacteriuria. So these are the kind of cases, most of the patients, who are given carbapenems, particularly in the outpatient settings, including ertapenem, is patients actually do not deserve getting carbapenems. It's not indicated. Okay, so one of the area which we have to really work hard is not to treat patients with asymptomatic bacteria. You don't have to treat them unless they are pregnant, or unless, immediately following renal transplant, or unless you are going to do invasive endoscopic urologic procedures. Please don't treat patients with asymptomatic bacteria. This is one of the problems that I repeatedly face. Patients are referred to me. So the challenge to diagnose CRE in Ethiopia is multiple, because we rely on phenotypic way of diagnosis, and this is actually an obsolete means, and we need, it's high time that we develop, or we have, the molecular and genetic tests. So this shows you that, a metallic chelator like Addis, this is a metallo-beta-lactamase. So with imipenem disc, you see the zone of inhibition. So like metallo-beta-lactamase could be inhibited by metal chelators, zinc chelator like EDTA. So we have really a problem in making the diagnosis, because we rely on phenotypic diagnosis, and the phenotypic diagnosis was underestimate. You get a false negative result as well as a false positive results. So it's very difficult. And just for you to see the difference with MRSA. MRSA is a single gene. It is that codes for MEK-A genes, that codes for PBP2A, and it is easy to diagnose. Now we have a point of care test that helps us to diagnose MRSA. However, for MDR gram-negative organic, these are multitude of genes, plasmid mediated, and very difficult. There are more than 200. So it's very easy nowadays to diagnose MRSA, but very difficult even the best centers, because the molecular tests identify, even the best centers, the most common ones. So what options do we have? If we think that these are the most valuable agents, the most, our last resort in the fight against bacteria, then how can we spare them? Because if we do not spare these agents, if we use them like we did with ceftriaxone, I think we are on the verge of collapsing. So all those gains, the surgeries, renal transplant, all those invasive procedures that are being done in our hospital and in Ethiopia in general, hip transplants and so on, the end result will be catastrophic if the bacteria keeps on developing resistance. So the options are now, if the blood becomes carbapenem resistant, then the options are to use colistin, polymyxin, ceftazidime, avibactam, ceftol. These are all drugs which do not have generic preparations and are very expensive. We don't have them. And in addition, they are all, except for the BLI, the beta-lactamase inhibitors, the rest have serious toxicity issues. And adverse effects are really of a major limitation in using these drugs. In any case, we have to improve our rational use, pragmatic use of antibiotics. First, we have to decide that we have to think that my patient have an infection, a bacterial infection, which requires antibiotics treatment. These are the 4 rules. And oftentimes it is not an easy decision. So if you decide on treating, then you have to make sure that you have collected the necessary biological samples, and you have to evaluate your patient every day, and according to his response and the culture result, you have to either de-escalate or if need be escalate, and you have to limit the duration of treatment unless for ventilator associated pneumonia or infective endocarditis to no more than 5 days. So antibiotic stewardship, we have to strengthen this. So we have come across, when we're doing this in the wards, we came across patients receiving vancomycin for 3 weeks without any good reason. And patients receiving meropenem, imipenem for 2 to 3 weeks. I mean, this is absurd. So we have to really strengthen our antimicrobial stewardship program, because this is a preventive tool. We have to really, it's like saving the Amazon forest. So the world is unless we save the Amazon forest, I think, the world climate change will get worse. It's like just equivalent to that. So we need to spare, to rationally use our antimicrobial, the available ones, because we are not going to have another addition. So the consequences are obvious, increased mortality, increased morbidity. So what options do we have? So in the MERINO trial, they tried to use Tazobactam for extended spectrum beta-lactamase producers. This means by definition resistant to penicillin, cephalosporins, and then monobactams. And what they have come across is the 30-day mortality rate is by far higher when compared to meropenem. So Tazobactam is not an alternative drug to use when there is extended spectrum beta-lactamase. What that means is the gram-negative strains into Corambessa, 2/3 of them are ESBL producers, meaning extended spectrum beta-lactamase producers. So the only option we have against this bacteria are carbapenems. So what we need to do is we have to limit the spread of ESBLs. Okay, part of the reason is, we use lots of antibiotics with broad spectrum and here, if you ask me what, do you have the best solution? Do you have a solution to spare carbapenems? I say, I don't have, sorry. But we need to work hard in order to rationally use, unless that's why we have to implement stewardship, and we have to really strictly abide by the rules. Okay, and a very important drug now available in Ethiopia is ceftriaxone sulbactam ADTA. I found it's very useful. So in critically ill patient, I advise you to use, before you use carbapenems, either piperacillin tazobactam or cefepime, or you can use ceftriaxone sulbactam ADTA. And then if you fail, you can use carbapenems as a last resort. But now I see you use meropenem, imipenem, and then you go for cefepime. This is absurd. It doesn't work. So carbapenems cover all except methicillin-resistant Staph aureus, Stenotrophomonas, and Enterococcus faecium. These are the only species. So if you want to add any agent on carbapenems, it should be vancomycin if you suspect MRSA. Okay, so I don't advise you to add to meropenem, cipro, fluoroquinolines, and the like, because carbapenems have adequate coverage. When you do so, you add to the problem of resistance. So the MERINO trial was the result was expected with lots of anticipation, but it was a negative trial. So piperacillin tazobactam cannot be used as a sparing agent. So in Ethiopia, the option we have is we have to really expand our microbiology service and also strengthen our antimicrobial stewardship programs, and infectious disease as a specialty should lead the lead, because this is going to be really a catastrophic process. So the other option now we do have is now people are trying to use a double carbapenems. Like, this is like a kamikaze. One of the drugs will be like kamikaze. If you remember, during the Second World War, the Japanese, they were kind of in suicidal mission. They load their warplanes with explosives, and they go directly to the ships and explode themselves with the ship together. So like nowadays, there is an approach to combine meropenem with ertapenem, and the carbapenemase will bind with ertapenem, and the meropenem will be released. So this approach, I found it really very interesting, but it's yet not widely expanded, the use. So we can spare, we can overcome, not spare, overcome, partly if we don't have colistin, tigecycline, ceftazidime, avibactam, and so on, like using a double carbapenems. And one is ertapenem. So these are, I have already discussed. So the key points are, carbapenems are the most important antimicrobial agent because they have the broadest spectrum. They are bactericidal. They have, they have a capacity to bind lots with very many types of PBPs, except PBP2A, which is coded by methicillin-resistant Staph aureus, and penicillin binding 3, which codes for Enterococcus faecalis. So it's a drug that we have to treat critically ill patients. So the widespread of ESBLs have made us use carbapenems a lot, and the expanded use of carbapenems added to the problem of increased carbapenem resistance. So particularly carbapenemase producing Carbapenem-Resistant Enterobacteriaceae has spread. As you could see, 2 years back in Korambesa, 20% of the Klebsiella and pneumoniae are already KPC. I have already developed Carbapenemase resistance. So this is really a serious problem, and lots of studies emerging from Egypt, Kenya, and South Africa have shown that And in the critical care units, CREs are becoming the dominant ones, particularly KPC, Klebsiella, Carbapenemase producing Klebsiella pneumoniae, and OXA48. So this is what I have, and if you have questions, and I'm interested to respond. Thank you very much. Teddy.
Okay, thank you, Dr. Anderson, for this timely update. Drug resistance really a big concern for all clinicians. Now the floor is open for comments and discussions. Any comments? Any comments and questions from the audience? Or you can write on the chat box.
There is an echo. So if there are no questions, then that's good. Thank you.
Thank you, Dr. Anderson.